Good afternoon and welcome everybody. My name is Rosanna and I am the speaker liaison for iCAAD. So, it is my great pleasure to introduce Dr. Antonio Metastasio here, thank you. And Dr. Metastasio has trained in psychiatry and more recently completed a master's in genomic medicine at the University of Cambridge. He has a special interest in personalised medicine, in psychiatry, and in addictions. He has extensively published in the field of depression, psychosis, alcohol, and substance misuse, and genomic medicine. Today's presentation is entitled Personalised Medicine in the Treatment of Addictions. This presentation's aim is to review the state of the art of personalised medicine applied to addictions, to discuss the ongoing scientific debate, and to identify which group of patients will benefit from genetic testing. I'm very pleased now to hand you over to Dr. Antonio Metastasio. Thank you.
Okay, thank you very much. And I think we're quite few, so I think probably it would be nice to have a dialogue rather than just a presentation. So please feel free to interrupt me anytime and to have a conversation. First of all, thank you very much for the Ad Council team that also made this presentation possible with all the IT support and also to arranging all of this. And I think that my eternal gratitude is with them. Now, first of all, what is personalized medicine? Because I'm sure we all heard about personalized medicine or stratified medicine, but what we are talking about? And as you can imagine, there are different definitions. I took three that I thought were the most relevant. The first one is the one from NHS England, and because it's fair to say that the UK is at the forefront of personalized medicine. There's been a lot of investment done by the NHS and by also other companies in personalized medicine and in genomic medicine, and that's very, very, very important. I mean, if you think that the DNA structure was discovered in Cambridge, there is still you have a big campus that's in the Wellcome campus where it's at the forefront of genetics. So again, NHS England and the UK has something to say about personalized medicine. So the first definition is personalized medicine is a move away from one-size-fits-all approach to the treatment and care of patients with a particular condition to one which uses new approaches to better manage patients' health and targets therapies to achieve the best outcomes in the management of patients' disease or predisposition to disease. So I think there are two things very important. We can treat patient, but also we can prevent that a disease occurs. And that's, I think, there are two very, very, very important pillars of personalized medicine. Then clearly we're still in the EU, I don't know for how long, but I think it's important also the EMA definition. The EMA is the European Medicine Agency, that is the regulatory body for new drugs that are introduced in the European Union. So it's something that, again, is something that's very important to listen to. And their definition is personalized medicine refers to a medical model using characterization of individuals, phenotypes and genotypes. When you say phenotypes, also to the external, how a person, all the external part of the individuals, and genotypes is the genetic of the individuals. Molecular profiling, medical imaging, lifestyle data, for tailoring the right therapeutic strategy for the right person at the right time, and or to determine the predisposition to disease and to deliver timely and targeted prevention. So again, also EMA stresses the importance of treatment, prevention, but also the right time. And again, this is something very, very, very important. And finally, the NIH. This is an American body, but again, it's the biggest. The biggest is the National Institute of Health, and again, clearly, their definition is important, and they're quite pragmatic and say what is personalized medicine is an emerging approach for disease treatment and prevention that takes into account individual variability in genes, environment and lifestyle. Interestingly, they also added environment and lifestyle. That, but particularly for us, when we talk about addiction and mental health, I think is very, 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 very important. But clearly we mention genomic. What is genomic medicine? Again, I'm repeating this because probably not everybody is familiar with these concepts, and genomic medicine is an emerging medical discipline that involves using genomic information about an individual as part of their clinical care, for diagnostic or therapeutic decision making, and the health outcomes and policy implication of that clinical use. So in a way, it is genetics applied to medicine. For us, it's very important because now when we talk about precision medicine and in addiction, clearly we need to talk about then pharmacological treatment. And therefore, we also want to talk about pharmacogenomics and what it is, pharmacogenomics. Pharmacogenomics is the study of how genes affect the person's response to drug. We are all different. Our gene setup is different. We all respond in a different way. And that's very important because until about 15, 20 years ago, every drug was tested on a very narrow group of people. If we think that, first of all, these individuals were Caucasian, in good health, and a lot of clinical trials, even in this group of people, probably they will take on board about 20–30%. So if you think that most of the data we have about medications is a very, 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 very narrow group of people. So whenever we start a new treatment, perhaps it's true that we should take a tablet once every 24 hours, but perhaps it's not so true. So pharmacogenomics is the study of how genes affect a person's response to drugs. This relatively new field combines pharmacology, the science of drugs, and genomics, the study of genes and their functions, to develop effective, safe medication and doses that will be tailored to the person's genetic makeup. Again, this is tailored to the person's genetic makeup because, again, it's important that we change the treatment according to the genes of the person. And what that means, improved choice of drugs. At the moment, a lot of guidelines that say start with this antidepressant or start with this other medication, but perhaps not in your specific case. Maybe in that group that we discussed before, yes, but maybe in your specific case is not the case. More effective and safe dosage. We will discuss later, there is a case of a drug that is widely used where it's fundamental to know the genetic makeup of the person, otherwise it can be dangerous. And it's a drug that most of us have used during our time life. And then also what is very important is improved drug development. Because I think at the moment we all know that we are, particularly in neuroscience, we're quite stuck. There are not many new drugs. So it is important that now we change the way how we also design new drugs that hopefully will be more effective. Now, personalized medicine has had the best results in oncology, cancer treatment. We all know that people that have a cancer now have a much better outcome than a few years ago, 10, 15, 20 years ago. Why is that? Because the introduction and the implementation at mass level of personalized medicine. Now, for instance, it is possible to do early diagnosis using biomarkers. Now, very, very, very hot topic is the so-called liquid biopsies. Now, often, for some drugs, for some cancer, it is possible just from a blood sample, peripheral blood sample, to diagnose or to think about that, there might be a cancer. So that's an incredible progress. Targeted therapy. We don't treat anymore, let's say breast cancer. We treat breast cancer with that specific mutation. Therefore, the treatment is different. So it's not for everybody, but it's for that specific mutation. And we can do also specific prevention. And there is a very famous example that we can discuss later. Again, liquid biopsies. You can see a tumor, a cancer, even when it's very small, perhaps it's undetectable with other the techniques releases some biomarkers. Particularly there is the tumor DNA that can be detected, and that makes a huge difference. But also, once we know that there's a cancer, and we do a cancer biopsy, now what we can do, we can find the mutation, the specific mutation for that specific cancer. And therefore, the treatment can be specific. A big game changer was the introduction of monoclonal antibodies that target specifically a mutation, and they can either help the immune system to kill the cell or deliver even a chemotherapy specific to the cancerous cell, nothing else. Or also small molecules that can enter the tumor cells and then can kill them. So you can imagine the difference. So now we are much more effective in killing cancer cells by enhancing the activity of the immune system, because now, with these monoclonal antibodies, they can signal the rest of the immune system, the tumor cells, and so they can be specific to kill this kind of cells. We can enhance, in general, the activity of the immune system. It is possible with these small molecules to disrupt the growth signals that cancer cells thrive on, and also to disrupt the creation of new vessels. So in a way, we starve cancer from new nutrients. And we can deliver chemotherapy, we said, in a targeted way. We can promote cancer cells death, and we can starve cancer cells from hormones. That, again, is one of the growth factors. Now, we all know this woman. This is Angelina Jolie, and probably you all know why she's here. Again, this is another example of a personalized medicine in action, in a way. Angelina Jolie's mom died very young, in her 40s, for ovarian cancer. And the reason was that she had a gene mutated, the BRCA gene 1 mutated. That means that she had a significant higher risk of developing either breast cancer or ovarian cancer. Sometimes they can happen both. So what Angelina did, she did a genetic test. They found she had the same mutation, and so she decided to operate to remove ovarian and I think also breasts in order to prevent the onset of cancer. And again, clearly this is possible because you can imagine it's a very big operation, and you want to be quite sure that you're not going to operate everybody that might be at risk, but if you have a specific gene that puts you at significantly higher risk. Okay, so also in terms of prevention, so probably she will die of something, but probably she will not die of ovarian or breast cancer, which is a very important thing. Now, that's a very simple question and very simple answer. Can we do the same in psychiatry, mental health, and in addictions? No. Do you have an idea why? Let's have a bit of an interaction, otherwise it's just me talking.
Environment dependent?
Well, also cancer is environment dependent. If you don't smoke, if you smoke cigarettes, most likely you will have lung cancer. Yeah. The problem is that we don't have biomarkers. I mean, at the moment you have a lot of researchers everywhere in the world trying to find biomarkers, for instance, for mental illness. But at the moment, for many reasons, probably because also our classification is not as advanced as the classification that for tumors, for instance, and for many other reasons, we don't have a biomarker. But also, if we think for cancer, despite the complexity of the illness, it's fairly easy, the mechanism. You have mutation in genes. When there are one or two mutations, of generally there are two, less people with BRCA genes like Angelina Jolie, there's enough one, then you develop a cancer. Okay? So it's fairly easy, at least as a concept. I found the mutation, I treat the mutation. Although, even there, sometimes if mutation is non-druggable, is not treatable, people will die of cancer. But again, it's a big step forward. In addictions and in mental health, it is more complex because we're not talking about Mendelian inheritance. When they say Mendelian inheritance, is like, one gene. I'm sure you might be fairly familiar, but we can talk about if you want. But mainly multigenic. Again, there is not just one gene of schizophrenia. We're talking about 50, 100, 150. Okay? So every gene gives you a bit of added risk to develop schizophrenia. And again, often there is an overlap, for instance, with bipolar affective disorder and schizophrenia. So most of the genes that associated with the onset of schizophrenia are also associated with bipolar affective disorder. So where we do discriminate. Okay? Clearly, it is much more complex. But then there is also something very interesting, because again, the environment, as our colleague mentioned, clearly the effect of the environment and not just and also how the psychological interaction and the psychology of the person is incredibly important. So as you can imagine, it is not so easy. Again, when we talk about mental health and addictions, we don't have a single gene, okay? So what we were looking at the so-called genome-wide association studies. These are huge studies where you take thousands of people, you start looking at hundreds or thousands of genes, and then you come with a panel of 50, 100, 150, 200 genes that each one has a very little effect, but then, as you can imagine, all combined together has a significantly more important effect. But every single gene, it's really nearly negligible, but I think it's important. Okay? So, what we are going to look at is the small mutations that can somehow affect when together and be responsible, or at least having a significant contribution of the onset of an addiction or a mental disorder. Okay, now, what we need to talk about, now can be a bit boring, but I think it's important to talk, and please ask questions or interrupt me if you disagree, is about pharmacokinetic and pharmacodynamics. Because as you can imagine, in addiction, unless we're talking about behavioral addiction, we are addicted to a compound, okay? And we all know that if we expose hundreds of rats or hundreds of humans to the same compound, not everybody will become addicted, and not everybody will become addicted maybe in a similar way. So there is something there. But first of all, let's talk about pharmacokinetic and pharmacodynamics. Okay, what we can say, pharmacokinetic is mainly what the body does to the drug. Okay, it's how the drug is absorbed, how it is diffused in the system, in the plasma, how then reaches the organs that are the targets, mainly the brain, and how then from the brain leaves. And that's very important. When we talk instead of pharmacodynamics, it's mainly what the drug does to the body, so how the drug interacts mainly with the receptors in the system. And that's very important, because I can give you heroin, but if you block the morphine, the mu receptor, you will not feel it. So in a way, it's very important, and the heroin, yes, it must arrive in the brain, in the central nervous system, but then it also needs to interact with the receptors, otherwise it does not have any effect. Now, it's important when you start talking about pharmacokinetic and pharmacodynamics to think about few characteristics that make a drug more or less addictive. For instance, compounds with shorter half-life are more likely to be addictive. We all know that if you have someone addicted to Xanax, alprazolam with a very short half-life, the first thing you need to do is to switch to diazepam. That is a longer half-life, because it's easier to manage and tend to reduce diazepam. So whatever makes, and that's why it's important to think about, whatever makes a drug having a shorter half-life makes that drug more addictive. And again, interestingly, and we'll discuss that later, the metabolism of drugs is different. We don't metabolize drugs in the same way, Everybody metabolizes drug in a different way, and therefore, not necessarily for me, diazepam is good and maybe for another person. Because if I am a fast metabolizer, probably diazepam would not be the right choice for me. Okay? Then there is another concept to understand. Faster a compound reaches the brain, that it mainly is the main organ, more likely is addictive. We all know that at the end, codeine, morphine, and heroin at the end are the same thing. They act as morphine in the brain receptor. However, heroin, as you know, particularly if you take it as intravenously, it is much faster. And we know that the addictive potential of heroin is significantly higher than codeine. Okay? So this is another important concept. So somehow, if people have either you deliver the drug in a way that reaches the brain faster, or for some particular specificity of the person, it goes faster, they might be more addicted, more likely to be addicted. Again, if we look about discuss about heroin, but again, the same is cocaine or stimulants. Crack, cocaine, and lisdexamphetamine. The lisdexamphetamine is advanced, is the treatment for ADHD. Crack is incredibly addictive because crack is cocaine-free base, smoked, so you can imagine, enters the lung, in no time is in the brain. But in no time is out of the brain. So a high of crack lasts a few minutes. Half an hour later, you are craving desperately for crack. Cocaine is slightly better, but still is not great because you go fast. And again, also it depends how you use cocaine. If you inject cocaine, it's much worse than if you snort, but still, it is quite fast. And then you have lisdexamphetamine, is another stimulant, but it's not addictive because it's slow released, and also is coupled with lysine, so it has to be decoupled from lysine, so it takes hours to work. I'm sure you know, but people that are using, for instance, Ritalin, methylphenidate, okay, if they want to misuse, they prefer to get Ritalin, crush it, snort it. That's why often now we don't use much Ritalin, we use more things like Concerta, that is, or other kind of modified release, because then it becomes much more difficult to misuse, to have an addictive potential. So it's very important to know how fast is a drug, more likely will be, people will have a high and people will be addicted to it. Again, we discussed earlier, alprazolam versus clonazepam. So, alprazolam is Xanax, clonazepam is Rivotril or Valium. There is another very long-acting, so they're much more addictive.
What about when heroin and crack cocaine is injected simultaneously?
Well, that's a very, very, very good question. Often people do that at the end. When people have been using a lot of crack, they're very high. Unfortunately, what happens is at first it might be even pleasurable, but then people can become incredibly anxious, incredibly paranoid. They haven't been sleeping for hours. You want to stop. So how do you stop? One way is to add to the crack something that is a stimulant, something suppressant, that is cocaine. Sometimes people use alcohol. Sorry, heroin, no, cocaine. And again, crack is a bit faster, cocaine is a bit slow, but again, yeah.
Some people do inject alcohol.
The extreme forms, can be inject alcohol, or can use also benzodiazepines, or, for instance, antipsychotics. You might not know, but olanzapine it has a street value because it helps you to calm down after you've been high for a while. So I think that is very, very, very important. Often people do combinations to try to achieve, to stop at some point, to sleep for a few hours.
And sometimes they have like a specific way of doing it. So
Yeah.
they put the crack first and then the heroin, or the other way around, depending on what they're finding.
Yeah, no. I mean, there are different styles. There are different. Depends also what is available in the market, or what the person want to achieve. Some people want maybe fast relief, then they go for heroin. Something a bit longer, they go for Valium. It depends. It depends. But again, a lot of people know that by injecting even alcohol, you have definitely faster action. Then it's extremely dangerous. It's incredibly unadvisable, but this is the nature of addiction. People would do the most dangerous things but this is the nature of addiction. Now, what I think is very important, now, I had this long digression about pharmacokinetic and pharmacodynamics, because I think now we were going to talk about personalized medicine. And it's very important to talk about the drug metabolism. Yeah, this drug, but clearly it's medication, but actually, when when this system evolved in animals, actually the fact is that there are a lot of toxic chemicals in the environment. You know that also potatoes are toxic, for instance, and we need to have a system that somehow detoxifies, otherwise we would be all dead. Eating salad or a few other things, they will be dead if you don't have a system that detoxifies. Then, when we start using drugs, clearly, then the same system metabolizes drugs, but was created, invented, or call as you want, selected in a way to metabolize all the chemicals that are in the environment. Now, you can divide the population in sort of 4 groups according how you metabolize a compound, okay? You can have poor metabolizers that have no gene or no function, so very little function. So the gene that synthesizes the protein that then metabolizes that specific drug, it doesn't work or doesn't exist. Poor metabolizer. Then you can have intermediate metabolizers, where this person metabolizes the drug, but at a rate that is a bit less than the normal metabolizers. So for some reason, maybe the molecule that is not so effective as the standard one, let's put it this way. Then we have the extensive metabolizers, the normal people in a way, so the people that metabolize this drug at a sort of normal rate. And theoretically, these are the people where when you say take an aspirin every 24 hours, is because they say on average the extensive metabolizers take 24 hours to metabolize this drug. But then we'll see that probably is not even true. And then you have the ultra rapid metabolizers. So people that often have multiple copies of gene, this is a gene, but we'll talk more about that. Or the gene for some reason is more expressed, so they have much more proteins that metabolize the specific drug, so they go much faster. And here when there are problems, because if you look at how drugs are metabolized, what does it mean? That if they say that diazepam lasts more than 24 hours, might not be true for someone that is an ultra-rapid metabolizer. Therefore, he might be addicted, or maybe switching to diazepam might not be the right choice for this specific person. On the opposite, if you are a poor metabolizer, even a dosage, very, very small dosage that it would not might not be effective in another person, might be toxic. Therefore, you might not want to prescribe a drug, that specific drug, to that person. Okay, now, this strange number, I'm sure you have seen it because I believe that you might have read something. So the CYP 450, this is a family of proteins called cytochromes. They are in different parts of the bodies, but the ones that are now of our interest are the one in the liver. These are the proteins that metabolize drugs. So make a drug either inactive or activate drugs. And that is very, very, very important, because some drugs enter the system, enter the body as inactive drugs, and then how the body metabolizes the drug activates the drug. Or can be the opposite, okay? So it's a huge family, 57 genes. We're not going there because very few people have an idea. Can you imagine 57 genes with very, 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 very complex. But I want just to focus on one of these genes, that's the CYP2D6. And this is very important because it's one of the one in mental health and addiction is one of the most important because most of the psychotropic medication are metabolized by this drug. Okay? Now, if you see this graph here, you can see that the prevalence of superfast metabolizers, poor metabolizers, intermediate and metabolizers, it is different according to the ethnicity. So, as you can imagine, superfast metabolizers are quite rare if you talk about Caucasians. It's quite interesting. Northern you go in Europe, less likely you will get superfast metabolizer. And if you think the kind of population that often then migrated in America, where a lot of the studies have been made, were white European population, so a lot of drugs were tested in people that most unlikely were fast metabolizers, super fast metabolizers. But if you see, for instance, in the yellow, people from the Arabic Peninsula and East Africa, the prevalence of super fast metabolizer is significantly higher. That means that the dosage that we know and that we use maybe in England does not apply, or we should be careful to use in other population or people from a different ethnic background. And we are all people that work all over the world. Clearly, our books that don't match what we found in reality. And that's very important because, again, if you see, for instance, the complexity. This is few opiates, because clearly we are talking about addiction and opiates are important. Okay? I mean, codeine, fentanyl. If you go in America now, you have these big epidemics of drugs. And you can imagine how, okay, important is to know if someone is a fast metabolizer or not. Because as you can imagine, you see what does it mean. And I'll give you a very practical example. Okay? These are just to mention that now there are guidelines. There are two big groups. One is this Clinical Pharmacogenetics Implementation Consortium that did guidelines for 22 drugs, but in the Netherlands they're much more advanced than for 86 drugs. And this is very important because now I'll make you an example. Codeine. Okay? We all know codeine. Most of us have tried codeine sometimes. Codeine is modified, is activated to morphine. Okay? Now, if you are a fast metabolizer, even a normal dose can be lethal, can cause over. There have been cases of people dying of morphine overdose given a normal dosage of codeine. And we say, okay, fair enough, in Sweden very rarely will occur, but if you are in Saudi Arabia, probably about 20-25% of people that are fast metabolizers. So you need to be very careful with prescribing codeine, okay? Again, what the guidelines say, obviously, if you are a poor metabolizer or an ultra-rapid metabolizer, avoid. The poor metabolizer, because clearly they will struggle to metabolize, but the ultra-rapid metabolizers will have this sort of rush of morphine that can be lethal, can be dangerous. Again, tramadol. Again, we have this huge, tramadol is an opiate, synthetic opiate, people like because you get a high from tramadol. I'm sure you have a lot of patients, clients, well as you want, on tramadol. And these are all people that, if they are fast metabolizer, clearly, you should either avoid or adjust, or be aware. Because again, it might happen that people get addicted to that, because the dosage that would be a normal dosage for the general population might not help them, and they might need to take more. Or they might have other symptoms. For instance, this is very interesting. Quite a few years ago, they've done a study on methadone. And they start saying that there is a group of people on methadone that appear to be depressed. Because they had, particularly in the morning, actually in the morning, in the afternoon, they started to have a low mood, a bit of fatigue, pain and aches, that somehow, if you are not careful and you go for you apply a depression scale, you say, okay, you are depressed. Interestingly, these people were fast metabolizers, so we read on our textbooks that methadone is a good thing because it lasts 24 hours, so stabilize people on opiates. But actually, if you are a fast metabolizer, it might not last 24 hours. So, for instance, these people were treated by giving methadone in divided doses. Or you might switch to buprenorphine or to other drugs. So again, it is important because we must know how you metabolize, because again, it might not hold you for 24 hours. So that's something very, very important.
A quick question. So, if we're a client who's on methadone,
Yes.
on a reduction plan,
Yes.
how would you then, if it's like a reduction plan of say on 4 or something like 12, how would you?
No, well, the fact is, if he's a fast metabolized, well, again, if it's fast metabolized for methadone, because methadone is not then metabolized by this enzyme, okay, so it's important. You may want to switch to something else, maybe Subutex. Because clearly, or you adjust the dosage, because clearly it's the sort of if you have the sort of it might not work as well as, and that might justify why maybe some people can tolerate well, the treatment with methadone, and other people might not. Again, it is important, and so this is important because again, when one of the point of my conversation is when you want to ask this kind of testing, it depends. If the patient wants and can afford, of course, always. But otherwise, you might want to recommend if for some reason that person, has a history of maybe of a poor response to medication or side effects. Again, when you have someone that says, yes. Yeah. Second? Well, it depends. Again, for instance, as I said, let's say if someone that has a lot of side effects sometimes you see not just the treatment for addiction, maybe antidepressants. There is a person that has taken all different antidepressants, had a lot of side effects. Maybe it's a psychogenic problem, but maybe it's because it's a fast or slow metabolizer. And again, let's say if you are a fast metabolizer and you take an antidepressant, if it doesn't last 24 hours, you might have some discontinuation syndrome during the 24 hours. So you can imagine it's quite unpleasant, and so you will not, if you are depressed, not only you will remain depressed, but you will have anxiety, you can have other unpleasant symptoms associated with this sort of discontinuation syndrome in a way.
If somebody is psychotropic naive
Yes.
and has never had substance,
Yes.
solid plan, right?
Yeah.
I mean, is there any guidance?
No, well, it depends, okay?
You give a trial of
You can do that.
or subjects within
Yeah, you can do that. Or, for instance, when you take the history, you might say, maybe in your family. For instance, where do you come from? Because genetically, let's say, if you come from the East Africa, from the Saudi Peninsula, you might be more likely to be a fast metabolizer than if you come from Sweden, for instance. If you have history, your family members that had problems, or because already start people doing tests, my mother did it and she's a fast metabolizer, so most likely that also the son or the daughter will have, might have inherited the genes. So it's more your clinical judgment rather than guidelines, okay? I mean, at the moment you can easily start without doing any genetic testing and check. No. Yeah. Again, the other question also you need to consider is this, okay, is the setting. NICE, like a lot of other guidelines, take in consideration the economy and say, is that really cost effective? Clearly, these are exams that are expensive, more expensive. No, not incredibly expensive, but we're talking about a few hundred pounds, okay? Clearly, you say, if the NHS should do this kind of testing, they might do anyway, because things are changing, so the prices are coming down, so they might do. to everybody, and then you can prescribe according to them. At the moment, they will say, if I do 57 million people, this genetic test will cost you billions of pounds. Today is not cost effective. But if you have a client, a patient that can afford, and one say, can we do this test? I would say, why not? Okay, so now we move to the pharmacodynamic, so how the drugs interact with the receptor, with the genes. And for instance, one gene that is very important for in addiction and in mental health is the SLC6A4 gene. This is the serotonin transporter gene. You might have heard about, SERT gene is called. There are two variants, the long and the short. People with two genes, two long variants, respond better than other people to SSRIs. When I say SSRIs, we're talking about the main antidepressants. You know, fluoxetine, Prozac, sertraline, Zoloft in America, and so on. But, for instance, if we want to treat for alcohol addiction, ondansetron is a drug that is effective, these people, the LL carriers, will respond well. People instead have the short gene, they will not respond so well. So, for instance, it happened to me in a few of my patients. You see a patient that is depressed, they'll tell you they've tried all the SSRIs and they don't respond, and often because they have the short allele. Now, if you don't do this test, you must start, with fluoxetine, then you say, okay, does it work? Let's try escitalopram, then does it work? Let's try sertraline. If you do the test, before answer, probably for you, an SSRI is not the best choice. Okay? One thing I forgot to mention, probably we are all familiar, when you say gene variant, are you familiar so it's, to make an example, it's like the color of the eye, okay? There are genes that are responsible for the color of the eye. The function is the same, but people can have blue eye, green eyes, brown eyes, black eyes, and so on. So there is a mutation there, and we know that, for instance, people with blue eyes, they're less, for instance, if they are in a very sunny place, they need the sunglasses or so on, more than people with black eyes, because there's been a sort of selection there. So it's like this thing. So the function is there, but in some circumstances it might be advantageous, in other circumstances it might not be so advantageous. Another gene that is very important for us in addiction is the OPRM1, the mu opioid receptor gene. So there are different alleles there, different variants, but the people that have this G variant seems to respond better to naltrexone for relapse treatment of alcohol use disorder, and we all know that naltrexone is very effective. But, if you have the G gene, the G allele is even better than maybe if you don't have, because in that case, maybe you don't want to choose naltrexone, you might go for acamprosate or other drugs. And again, interestingly, now we have been talking about Subutex methadone, there are a variant that might show a better response to methadone. For instance, at the moment, a lot of literature shows that probably buprenorphine might be better than methadone for many reasons. But in few people, maybe methadone might be a better choice. So I think it's helpful to know that. And then there is another gene, this GRIK1, that is glutamate receptor, and people might respond to topiramate if they have a variant of that. So topiramate normally is not very used in the UK, more used in America, but you might have a rationale to use topiramate also here. Again, these are the sort of, because then there are other genes that, for instance, are associated with some behaviors. For instance, COMT genes seem to be associated also with impulsivity. And again, we know that impulsivity is an important factor for addictions. But again, this is something is more research, that I think at the moment there's not hard evidence to say, yes, we can use this kind of testing in clinical practice. Now, just a bit of water. Okay, so what's next? First of all, any question here or any? Okay, so now, have you heard about microbiome? Okay, that's very important. Okay, we have the definition. It's important. Yeah, microbiome is something extremely interesting. What is microbiome? It's the collective genomes of the microbes, so that bacteria, fungi, protozoa, viruses that live inside the human body. Okay? We know the gut is full of microbes, the skin, everywhere, probably everywhere in the body, there are bacteria. Probably even in fluids like, with milk and so on, everywhere there are bacteria. And there is a lot of DNA there, much more. Apparently, we have about 10 times as many microbial cells than human cells. And there is a lot there. The scale is incredible, okay? What the microbiome does, a lot of things. The bacteria in the gut, they do a lot of things. They protect us. Again, you have this, I'm sure you heard about good bacteria, bifidus and so on, the people drink this. Because in a way, by lining the gut, prevent aggressive pathogenic bacteria to grow. Okay? So if your intestine is healthy, you might not get infection that maybe other people could do. Then they produce a lot of vitamins, particularly vitamins K and B12 that are produced by this bacteria. They're not produced they're very important. They also stimulate the immune system. Because as you can imagine, particularly children, when they start colonizing the intestine, they produce a lot of antigens that the immune system needs to respond to that. And then you reach this sort of truth in a way, because clearly the immune system keeps the bacteria in check, but the bacteria continue to stimulate the immune system. Then in the stomach, in the intestine, promotes angiogenesis, the creation of new vessels. That is very important. They seem to be associated with fat storage. Interestingly, now there are studies that show that the kind of bacteria you have in the intestine, they're more relevant than the DNA that you have in terms of risk of obesity. They've done studies in identical twins, and one is obese and one is not, and the difference is not the DNA, clearly, is the gut. Okay? Then what they produce, these short-chain fatty acids that are very important as signals for cells and for the brain. Apparently they have a significant impact, and then they act by modulating also the central nervous system. They are associated also with depression. Again, these short-chain fatty acids that are synthesized only by the bacteria, they somehow are associated in the metabolism of three things. Tryptophan, it's funny name, but it's an amino acid. It's an essential amino acid, so it's created only. It's not created by the body. You need to eat, and and serotonin is synthesized starting from tryptophan. So, if you starve someone of tryptophan, you might cause depression. One way is to eat dark chocolate. It's rich of tryptophan, so that helps you with mood. But that's very important. Tryptophan can be then used in two ways, either to synthesize kynurenine that causes inflammation, and we know chronic inflammation causes a lot of problems to the system, or to synthesize serotonin. So if you have a if you have a good bacteria that produce a lot of short chain fatty acid, you switch this metabolism towards serotonin. Otherwise, you might switch towards more kynurenine, means inflammation, depression, and other problems. And again, there is this leaky gut syndrome, where if you don't have, in a way, a healthy flora there, healthy good bacteria, the intestine, the lining of the intestine can be damaged. So, as you can imagine, in intestine there's a lot of stuff, a lot of food, a lot of food that getting processed, and you want to absorb only really what you need, not everything. What happens is, you can see in this picture, that somehow the cells can become a bit loose, and therefore, when the system works properly, every compound is selected and transported inside, clearly then it's loose, so everything can enter the vessels at the end, and then causes a lot of problem. Now, if you go to addiction, there is a lot of evidence that people with alcohol abuse, cocaine and opioids abuse, they have a dysbiosis, means that they have a pathological bacteria in the gut. Now, probably is a chicken egg problem in a way. So perhaps the kind of diet they do affect the intestine, but vice versa as well. And again, there is a lot of evidence that people that, for instance, they study much more for depression. People with dysbiosis often have depression, and sometimes there have been evidence of people treated with the so-called fecal transplant. So they got this bacteria, good bacteria, and by the way, it's very important to have a very varied diet. So that also, with improving the flora, the bacteria in the gut, then also the mood has improved. And perhaps we can argue also the addiction. And now, you know, we have this link between alcohol use disorder, eating disorder, and other mental health conditions. Again, what we can do now, we can check. We can take stool sample and check the microbiome. Not just that. We can, because then clearly the approach then will be, you do a specific diet, you do a lot of things, but also you can monitor how the microbiome improves with treatment. Because at the moment we know that there are different microbiomes that have been, because we don't know much, okay? So there are a lot of studies now that sampling. And so we know roughly what is a healthy microbiome and what is not a healthy one. And then basically we can monitor, say, are you switching from an unhealthy towards a healthy one? And that's something that definitely we can do. The last part of this talk is instead on whole genome sampling. And that's, I think, is something very exciting and very new in a way. I put this slide here because it is something very exciting, because it happened during our life, not just our life, but probably during our professional life in a way. If you see, there are two lines here, the white one and the green one. The white one is the Moore's law. Now, I didn't know that. When I was studying this stuff, I learned about the Moore's law is a law that has been invented for IT, where every year you have you double the potence of the power of microprocessors, and you half the price. And there is this kind of things. You know, we all know that when computers start to have quite slow, quite big, quite bulky, and very expensive. Now, you know, they're very, very, very affordable and very potent. But the green thing instead show the cost per genome. When we say genome, is the entire DNA of a person, or of an animal, or of a human, or of a living creature, because also vegetable, you know, it can be. Okay? So we went from 2000, that was 100 million dollars, sorry. When they did the genome project, I'm sure do you remember that at the end of the 20th century, really, you know, there was this genome project where every nation took a chunk of genome, a bit in America, a bit in the UK, in Italy, wherever, also private, say, okay, we'll sequence this. It was incredibly expensive, but, you know, to sequence a genome we're talking about hundreds of millions of pounds, of dollars or pounds or whatever. But if you can see, in 2008, because then they came with this new, with the progress of technology, the price dropped to the point that now we're talking about around $1,000. So in the span of less than 17 years, we were talking about a price that not even the richest people in the world could afford for themselves, to now something that is, we're talking about £1,000 or even less. So you can imagine, but then what you get? You get the entire genome, everything. And what is very interesting is that again, this is all genome sequencing. See the magnitude, the scale. When I was talking about genes, you know, fast metabolizers, slow metabolizer, you do an array. If 50, so it's not very heavy, and you get some. You have some specific gene, and you see some mutation. Not even all of them, but the mutation that most likely are the most relevant for that specific gene. Then you can do exome sequencing. Now, just to explain what the difference is, I don't know how familiar you are. So genes, DNA is divided in you have the biggest part of DNA is the so-called junk DNA that probably is not junk DNA, but is very important. I will discuss later. But then there are the genes. The genes are divided in there are two parts of the genes. The exons that are then codified and then become part of proteins, and the introns that do not express proteins but are important. So clearly, one way is that we check just the exomes, so we see every protein that the body can produce, and clearly it is bigger than an array, but it's not so big. But then we can sequence the whole genome, and we get everything, including the junk DNA. Now, it was junk in the past, because we didn't know what, but it's very important. I mean, if you see the biggest difference between a mouse and a human is the amount of junk DNA. We have much more junk DNA than a mouse, so probably it's not so junky as we think. So, what is the advantage of this technique? That gives us a high resolution base by base of the genome, so we know everything. We sequence everything. It can also get small or large variants that might be missed. When I said with the arrays, you just check a single gene. But if for some reason you're not very usual in a way, and maybe your gene is situated in a different area, whatever, that can be missed. And that's something that's very important. And then also, what is very important is give you some variants that can help in the future. So again, it's not something for now, but also for the future. So for instance, this is what you get, okay, because this is quite interesting. This is genetic susceptibility of alcohol dependence. So again, when we are talking at the beginning, you don't have one gene that say you become an alcoholic or not. You have quite a few genes. The red line is basically the sort of the result of a GWAS study. So when you say you take a huge population, 3,000, 4,000, 5,000 people, you check all the genes that are somehow associated with alcohol dependence, and then you say this is a sort of average, is the red line. This person has a lower risk of alcoholism than the general population, but probably has, for instance, a higher risk of bipolar affective disorder. That doesn't mean that this is a person that will develop bipolar affective disorder, but if you take the general population, that has more of these genes that have a little effect, but together becomes an important effect of, yes?
Just a good question. You know, the basis, so the collection of different genes that you have
Yeah.
for the test,
Yeah.
regardless of general population,
Yeah.
is there still samples being collected for it?
Yeah, that's the fascinating thing about this stuff, is that it's always, every day, there are hundreds of new articles about that. Every day, so now the trend is, we're going to bigger and bigger database. Again, I'm sure you heard here in the UK that they just completed the 100,000 genomes. So they collected 100,000 genomes, okay? In America, of course, they do things bigger, 1 million genomes, and they're growing and growing. Other countries now, they're doing their own genome project in a way. So what we're getting is more and more and more. So if we do a GWAS study, before big number was 4,000 people, now we can say, well, actually, we can do the same for 1 million people. So every day things are changing. So what is fascinating about this test is when you do it to a person, what you need to tell, the information is there, your DNA will be there, will not change. What every day will change is our knowledge. So now, for instance, the advice often, once you have sequenced the DNA, every 6 or 12 months, you should go through again it, because maybe you may have a variant that wasn't considered pathological that may become pathological, or vice versa. Things that at first with small samples we thought maybe this gene means that you might develop this kind of cancer, perhaps then when you get bigger sample, that's not the case. But that's clearly is fascinating, because clearly you do a kind of test like that and you can check everything. The risk of bipolar fatty disorder, but also your risk of obesity, cardiovascular disease, cancer, whatever you want. But also, are you a fast metabolizer? Are you not? Are you related to the royal family? Are you not? Because again, you can do also this genetic test. It's true, because now clearly you can check and say, that you have database of everything. And so I think that's really clearly the potentiality of this. It's incredible. And again, now has become fairly affordable. We're talking about hundreds, thousands of pounds. We're not talking about $100 million. And that's it. So I don't know if you have any question or anything you want to talk about. Yeah.
I've heard that, I'm no expert on this at all, I've heard that genes can be switched on.
Yes, true.
They
Yeah.
move.
Yeah.
How does that fit in with what you've been saying today?
Well, that's a very, very, very good question. Okay. Just let me step back 1 second.
Okay.
Before the genome project, when I was studying at university, they said humans have probably 100,000 genomes. Actually, we have probably 25,000, 30,000 genes. Sorry, not genomes, genes. And the reason is that genes can be, and proteins can be switched on when you need, on and off. Often according to, there is a change in your environment, you activate some genes that somehow are protective or not, okay? But then it can become pathological as well. But also, the same gene, when we're talking about exomes, exome means you have a line, you have part of DNA that synthesizes for the protein and part that don't. You can even assemble the protein as you want. So, here let's say there is, in some circumstances you produce one protein with, 5, 6 exons, but on the same gene, in other circumstances, you do 4 exons. So the protein is different. The gene is the same, but you can do 1, 2, 3, 5, 10 different proteins from the same gene. And again, genes can be activated. There are some genes that are activated only when there is a somehow specific threat or something in the, again, I'm sure we all like the red oranges. If you see the red oranges, the red oranges grow only in some specific places, mainly in Sicily, in the Etna mountain. And the red pigment, which is very potent antioxidant, by the way, is very healthy. I recommend eat a lot of red oranges. Is switched on only, the gene that produces that pigment, only if there is a huge difference of temperature between night and day. The same applies for grapes as well. Again, that's why they say that they recommend to, generally better wines come from where there's a quite difference between night and day, and because that switches some genes that are associated with pigment. It protects the cells, it protects the plant in a way, and also gives this sort of byproduct that we like.
Do you think we will move forward to using fecal implants as a preventative?
I don't know. Probably not, because I think probably what will happen we will be able to prescribe better diets. What we should aim is actually to get, I mean, the fecal transplant has been used mainly in people with this, that had a very bad infection of a C. difficile. They need a lot of antibiotics, and this was the only way to, well, this is sort of life-saving treatment. Then seems to be effective, again, most studies are mainly sort of animal studies. It even can be used to treat obesity or to treat other conditions. But what I think at the moment the aim is that to design diet that probably will be tailored to that specific microbiome. So it's not anymore the diet, well, 100 calories of this and 200 grams of that. No, specific to your own microbiome, because what we want to switch is from A to B, from unhealthy to healthy. And then probably that will cause weight loss and maybe another kind of improvement. So, but clearly it is something that it is possible, it might be possible, maybe will be even more used because clearly we will know more, we'll have more databases of healthy microbiomes. Because again, at the moment it's a risk, because you might say, yes, maybe this transplant is someone that is healthy, maybe for one reason, might not be healthy for another reason. So again, not necessarily having a fecal transplant is going to solve your problems in terms of microbiome. Any other question or anything? Okay, so I think it's so I hope that was interesting, this talk, and